Yes.
Thank you, dear Selin, for your invitation. My topic is endonasal endoscopic approach to rare skull base pathologies in childhood. First of all, I would like to thanks to İzmir University Department of Neurosurgery, especially Professor Kamil Sucu and Associate Professor Selin Bozdağ for the kind invitation. So if we write the PubMed to literature, transcranial pediatric plus microscope, we can find only 7 results. But if we write there plus endoscope, we can find over than 300 results. So we can observe this increasing very clearly. And for skull-based pediatric and plus microscope, we can find only 22 results. However, if we plus their endoscope, it's go like 500 results. So this increasing is very dramatic maybe. So we can say that endonasal endoscope approach is the most popular approach for skull-based pathologies in children nowadays. There is some advantages, of course, maybe about the philosophy of this technique. We can use forehand, four eyes, with, of course, our with ENT team, and for operation strategy, two brains we can use. And of course, there are some disadvantages of this technique, like two-dimensional approach. And for us, for neurosurgeons, it's relatively new technique and long learning curve yet, and also a good technical infrastructure is so important. There are some additional disadvantages for children. These are the small nares for use our tools and unpneumatized sphenoid sinus for space. So we need an adequate space to use our tools, and also at this time maybe we must create a sphenoid sinus for these children. And suitable equipment is so important to use them. And of course, technology is mandatory, like a neuromonitoring system and navigation system is the mandatory. So in the literature, we can see a lot of studies nowadays about the skull base of the children for endoscopic approach. In our series, this is the before 6 years ago is published. Now it's over than hundreds patients, but at this time it was 54 children. And as you see here, the half of them about the craniofacial and pituitary adenoma. However, there is a lot of very rarely diagnosis and pathology also we can operate with this way. So we can say that approximately half of the patient is craniofacial and pituitary adenoma. However, about 40% of them rarely pathologies. So for this lecture, I don't talk about craniofacial or pituitary adenoma, but for others, we will talk. So at this time, if you write to the PubMed others, we can find this poster. It is Nicole Kidman movies, and they said sooner or later they will find you. If you're interested with the cellular endoscopic pathologies, skull-based pathologies, sooner or later we will find the others. And these are Ratlaka cleft cyst, ordoma, dermoid tumor, and the others. So we will talk about them. And in our series, in our clinic, there are a lot of these rarely report are published in the literature before. So I want to share some cases and some pathologies of them. These are first the germ cell tumors. We know that it's typically affecting the midline structures like pineal and cellular region. And we know that they are so chemosensitive and radiosensitive diagnosis. So if we take a biopsy, and it's best way, maybe endoscopic way, it's very important for the treatment of these patients. Another pathology is astrocytomas. It's 1/3 of these tumors are origin from supracellular tumors. And nowadays is we use endonasal endoscope approach for these patients. Another important diagnosis, histiocytosis, and this is maybe the most common of the CNS tumor about histiocytic tumor. And we know that chemotherapy is the main treatment of this pathology. So it is so important to take biopsy with endonasal approach for this patient for the follow-up. Hypophysis, another important and very rarely diagnosis. It is clinically significant patients, and the diabetes is frequently seen. And if we, again, for this patient, biopsy is so important. This is one of our patient with this diagnosis is 12 years old male. He present with hypoplasia and total ophthalmoplegia on left side and hypopituitarism. And 1 month later, the tumor become larger. And with our oncologic conseil, we decided to go with endonasal endoscopic surgery for biopsy. And it was hypovisited at this time. So after medical treatment, as you see here, 3 months later, it become smaller. And in the 1 year later, there's no any tumor, any mass in the area. So what's the importance of the biopsy just for the endonasal approach? And 1 year later, after and before treatment, there's no any mass in the area again. Of course, some bone lesion is so important for the skull base for the children. These can be fibrodysplasia, osteoma, or giant cell tumor of bone. I would like to share some of our cases again. This is 15 years old female. She present with the headache and breathing difficulty and visual and olfactory disturbance. Of course, maybe transcranial approach is one of option for this patient, but we decided to go again with Endonasal endoscopic approach for this patient. First of all, we prepare hot dot flap. Sorry. It is so important because of the protect at the end of protect of CSF leakage. Now we are preparing with our ENT team the hot dot flap, and then we go inside the tumor. It's little hemorrhagic one. We try to coagulate the area with its vascularized system, and this is the capsule of the tumor. We try to debulk the tumor. Of course, unfortunately, it's one of hemorrhagic one. Piece by piece, we remove the tumor. It's one of huge one, so it's not easy maybe remove totally, but we can try for that. Of course, using the navigation system is so important for this patient. Now we drill the bone to reach the area, the larger area. This is the diaphragma cella, here you see, and we reach there. Some part of the tumor detached very tightly to the normal tissues. So we find opportunity to remove all the tumor. As you see here, there is no any remnant tissue on the area. So it's so important after that the repair of the this patients. This is the preoperative and postoperative MRI. It was a giant cell tumor of bone. In the sagittal section, there is no any tumor in the area. But not only for the tumor, also some congenital anomalies. We can use this system, endonasal approach. This is the one of sample for that. It's basilar invagination, and he was 14 years old boy. He presented with swallowing difficulty, neck pain, and clumsiness on upper and lower extremities. And you see, as you see here, the os odontoid is the compressed brainstem, and in the MRI there is a very narrow area for the this patient. And in the grab measurement, it was over than 1 centimeter. So we decide to operate him, and we go again with endonasal approach. Of course, first of all, for stabilization, we operate in the posterior occipitocervical stabilization, and then we go with the endonasal endoscopic odontoiectomy. And here you see there is no any bone in the area of the compression, so the compression is comfort. However, there is some lesson learned from this patient. There is the clinically was harmful, but then 2 weeks after operation, the patient after violent sneezing, he got a headache and lethargy. And here you see the CT scan. There's full of the air in the brain. So we again with urgent surgery, we prepare for the endonasal endoscopic approach. And at this time, it was so important to use a nasoseptal flap. After that, again, clinical condition was improved. And as you see here, the CT scan is totally normal. So we again published this lesson from our learns in the literature. And cephalocele is another congenital anomaly, which we can use again this technique. This is only all 6 months male baby. He had a breathing difficulty, and pediatric clinic referred to us for operation. And as you see here, there is a mass all in the corner, and there's no for air way to take it. So this baby had a breathing difficulty. Again, we prepare for the Endonasal Endoscopic Approach. However, there is some disadvantage. Here you see there is a very small nares and no any sphenoid sinus. So it's one of the difficulty of this operation, but we decide to go again with Endonasal endoscopic approach because the best way to reach here there. The first stage of the operation, we use intrathecal sodium fluorescein because of we must observe the CSF leakage when we remove this mass. We know that we must face with the CSF. So we prepare at the beginning of the operation. Under blue light filter, we know that we can observe this leakage. So this is the operation. At the beginning of this operation, here we can observe the pulsatile mass here. It's full close to the corona, and there's impossible to breathe from here. So our first target to take this mass from here. Of course, we use the navigation system on all the equipments. Just I must go a little rapidly. Of course, we prepare the hot dot flat. Is the maybe another topic must be topic, but it's so important for this pediatric patient for the huge pathologies. Now we prepare it, and I must go a little fast because of time. I'm sorry for that. And now we reach this mass, and our target is take from its peduncle. Here the peduncle, and we try to cut from here. First of all, we must remove the mass. And now we find opportunity to take this all mass from the area, and we remove it. But we know that there is some amount of this pathology still, and CSF leakage maybe occurred from here, this area, and of course we must prepare there additionally. Now I will go again little fast. Yes, we use silver clip for close to this mouth, and now we did it. And after that, of course, repair is so important. And then we finish the operation. And after operation, here you see there's no any mass in the corona, and the all areas decompressed. After operation, the clinically improved for baby is very better for him. And after 6 months operation and after 1 year's operation, there is no any problem in the area. It's full of open. So also we published this important technique in the literature again. And of course, we can observe not only congenital anomalies, and some cellular region can occur in this area, not craniopharyngioma, not pituitary adenoma, but for this patient, for example, it's another kind of the pathology here we observe. This 9 years old girl, she present with visual disturbance, and in the another center, she had 2 times transcranial approach. However, it's take only biopsy, and it was a dermoid tumor. And in the follow-up, you can see here there's still a remnant tumor on the cellular area. So by time 3 years later, she presented with amaurosis to our clinic. And we decide at this time operate with the endonasal approach. First of all, again, we prepare the hot dot flap. Now we are going inside the dura. Is damaged by the tumor. It's typical dermoid tumor, as you see here. Every neurosurgeon likes this kind of tumor very much because it is so easy to come to the aspirator, and also the border is so clearly to notice it. So now we remove the tumor by aspirator. We can use curved aspirator for that, as you see here, and sometimes we can use 30-degree endoscope for look to all the area. We can use the water here and as the tumor go outside the capsule. And the stalk, pituitary stalk, when we remove tumor, the normal tissue we can observe for this patient. And this typical dermoid tumor. At the end of the operation, there is some remnant when we use double curette for take it. So this is the early post-op MRI. There is no tumor in early post-op MRI, but unfortunately, it is not commonly. But post-op second week, because of the hot bath. After hot bath, the rhinora come for this patient. And so we again take endonasal endoscopic repair for this patient. And after this operation, the clinically improved again. And in the follow-up, there were no rhinora. But it's not ended yet, unfortunately. And this is the operation of the endonasal endoscopic approach for the rhinora for this patient. Of course, you must use filter for that. And when we use the filter to observe, there is no any sign of the CSF, but in the up and on the left side, there is some green color area. So we decide to go there here, and we decide to go there, and after operation, the clinically improved again. But it's not the story finished yet. Unfortunately, second month after operation, she became with the amaurosis and then lethargy. And here you see there is some transition in the T2 MRI, and we take for the urgent VP shunt operation for this patient. And then after 3 months, there is no any hydrocephalus or tumor. And as you see here, after 6 months and 1 year, there's no any tumor. Here, there is no any remnant tumor you see. The dermoid tumor also we can observe in some skull base of the midline. Here, 5 years old boy. He presented with headache and growing mass. And there is a here channel to the nerves. First of all, ENT team for reach the skull base, remove this channel, this tunnel from the this pathology from the nerves, and we follow this um, pathology, and of course we will reach to the origin. Its origin from skull base. So we reach here, as you see, we reach to the skull base, and we at first stage we remove this tunnel totally. Then again we go for endoscopic approach and we prepare hot dot flap first of all. Again, I must go a little more fast. And now we reach the tumor here, and this is the we remove bone more to enlarge the area. And this is a typical you will see dermoid tumor when we cut this mass capsule of mass is typical hairy mass we can observe. So it is dermoid tumor again. And for this patient, we remove totally. And it is mandatory to repair the very well this area. Here you see from the frontal sinus to cellular area, we repair all the area with the fat, hot dot flap, and the fascia lata. And after second year, there's no any tumor in the area. I don't go to details, but sometimes we observe some chordoma in the very age of young children, and here one of them navigation and the other system using is mandatory. Just it is another type of the pathology is 14 years old boy. He had a traffic accident 1 month and he presented with the rhinore and Beta transfer was positive. Here the defect of the you see the bone, and also in the MRI there's a T2 weight section. There's a some CSF, and we operated, of course, again with endonasal approach. You see the CSF color now is green because of the sodium fluorescein, and here in the again left side it is like a light of green is full of the CSF origin of the CSF leakage. So we repair there. Of course, it mustn't do without the hot dot flap. We prepare again, and I don't go to details, but we repair this area in the multi-layer technical system. After 2 months, there is no any problem for this patient also. This is my last case. This is 7 years old male. Of course, every time we couldn't see here some tumor or congenital anomalies. This is a very different type. This is he had a severe headache and his neurology was intact. And this is the operation movie again. We go endonasal approach for this patient again. And when we reach the dura and when we open it, It was a abscess of the cellular region. So it's one of the unique, again, very rare pathology. And of course, the main treatment will be with the medical and antibiotics and the other therapies. So we did it after the operation. And in the second years, as you see here, there were no any mass oral remnant for this patient. So as conclusion, endonasal endoscopic approach is a safe and effective surgical approach that can be used not only for the cellular region tumors, but also for managing various skull base pathologies, not only for adults, of course, also for the children. I would like to thanks to my departments and of course the our colleague otolaryngology department for their support and their series, and thank you very much to the audience for their attention. Thank you.
Thank you, Professor, for this detailed presentation. Great cases, great videos. It was an opportunity to learn from you. Thank you again. There is a there are two questions from Professor Atilla Kazancı.
Before that, Professor Gökmen Kahiloğulları, can you stop your screen sharing because
Sure.
we can see each other bigger?
Sure. Okay. Thank you.
Thank you.
Questions from Dr. Atilla Kazancı from Ankara Bilkent City Hospital. First question, do you often perform lumbar drainage to prevent post-op CSF leakage routinely?
To be honest, we never used lumbar drainage in no any patient. Just I showed one of the dermoid tumor we operated second time for Renore. Just we used for this patient, but for lumbar drainage we never used. We believe the power of the hot dog flap and the repair technique, of course, with our ENT team. So and also the pediatric patients give better results than the adults for CSF repair. So we never use lumbar drainage for the pediatric patient with Endonasal Endoscopic Approach. Only one case that I shared it.
Thank you. And second question, is there a cutoff age for children for endonasal endoscopic surgery? What is the youngest child in your practice?
Yeah, I think there is no any cut age for that. One of our patient, as I shared before here, he was only 6 months young. So it's not depend to the age. I think if you have enough experience and enough equipment, maybe we can operate maybe younger than the 6 months. But of course, it's not competition. But our younger baby was 6 months. Yeah.
Thank you. And there's a question from Dr. Ali Karadağ from Health Science University, İzmir. Thank you very much for your excellent presentation, he said. Do you prepare hot dot flap for all your pediatric cases, or do you decide whether to use it based on patient's age or the extent of huge tumor imaging?
Yeah. No, we don't use, we not prepare for all patient the hot dot flap. For example, if it's in the only cellular region and small tumors, we don't use it. But if it's a big one, for all craniofaryngioма and for big tumors, of course, we prepare. It not depend to age, but it depend to pre-diagnosis and maybe the mass big giant tumors. But not for all the patients, of course.
Right, thank you. And there's a thanks from an international colleague. It was a great presentation. Dr. Mohammed Noman.
Yeah, Mohammed Noman. He's my friend. Thank you. Thank you, Mohammed.
And If there are any question from participants, they can write in the chat part. I have one question. What advice would you give to young neurosurgeons who wish to develop their skills in pediatric endoscopic endonasal approaches? Where and how should they start their training?
Very good question. We are neurosurgeon, and maybe endoscopic approach is one of not familiar to us because we all very familiar with the microscope, but endoscope little different for us maybe. But I think the best way maybe first of all observe this kind of operation. If is there is no in your clinic, maybe in the some center who operated in the big numbers of the patients. And for especially for the pediatric patients, first of all, maybe it's better to start with the adult patients, and then after maybe 300 patients of the experience to go to the pediatric patients. Of course, in Turkey, there is a lot of center with very familiar with this kind of operations, and of course abroad. So I think it's first of all is observation. I think.
Yes. Thank And there are many thanks from Dr. Erkan at the City Hospital and Dr. Onur Davutdağ sent his thanks and a question. Do you administer fluorescein intravenously? How do you adjust the dose for CSF leakage?
Of course, we use in the after the at the beginning of the operation. So we use the intrathecal way for that. Uh, I give the details of the is volume in my presentation, but of course it's depend to the patient's age, weights, and etc. Uh, and we don't use for all the operations, of course. If we believe there is some CSF leakage, we maybe use it, or some kind of the operation we believe in the during the operation we face with the CSF leakage, but not all for all patients, of course.
Thank you, Professor. And there's an international colleague, Dr. Nikolaos Sirmos from Greece, want to talk about his comments and contributions. If
Yeah,
we
okay.
can open the...
I sent a request. Okay.
Hello, everybody. Good evening from Thessaloniki, Greece. It is a great pleasure and an enormous honor to have in my screen my dear friend Gökmen Kahiloğulları, Professor Gökmen. We are friends since 20 years. She was my trainer in international basic neurosurgery course in Antalya. And since then, we are close friends, also with Meli Boskurt. Since many years, I follow his activity. He's a true master of pediatric neurosurgery, and he's a true master of these approaches that he described before. Here in Greece, we have an enormous hot, and this is it is very hot, the climate conditions. Dear Gökmen, brother Gok, you are a true master of neurosurgery. I'm very happy and very proud that I'm your friend, and I hope to see you perhaps in the next year's Congress, to see you in real life and not in my screen. Your teachings, what are you saying, are a very good lesson for our good colleagues across the southern, eastern, and all the Mediterranean region. But it's also good lesson also for us, the experienced neurosurgeons. Compliments and best wishes, and it is a great lesson. I followed it, but I have some connection problems, and thank you very much.
Thank you, dear Nico. I'm very happy to see you again and to talk with you. Thank you very much for your beautiful words. and hope to see you as soon as possible. Thank you, Nico. I'm so
Okay.
happy.
It is the truth. No words because we are close friends. It is a truth.
Thank you.
Okay. And compliments to Dr. Celine Bozdak for making this very nice, very important webinar. Thank you very much. Great honor
Thank
to be
you.
with you.
Thank you,
Thank
Nico.
you. Thank you for your contribution, Professor. And
Of course, I thanks to Suju and Bozda. It's a very beautiful connection with several years, and thank you for all this your efforts again.
Thank you.
thank you. And there are some things. Dr. Ayman Abu Bekir asked, "Is there any training chance available?" He asked.
Chance.
Uh,
Is there any
chance,
chance? Sorry.
training.
Chance. I think he is implying your site, at your site.
Yes, in your institution, I think. I
To
understand.
training in our clinic, right?
Yeah, I think
I
so.
understand that.
Yeah.
Okay. Every time for all our colleagues from Turkey, from abroad, and they are still coming, and we are so happy for that. Of course, we are all time, me and our clinic and our team are every time ready for any practice, any observation, and all of them. Of course, please write me, and of course, it's a great pleasure to meet with them, of course,
Professor
every
Gökmen
time.
Kahiloğulları, maybe you can write down your email address on the chat part, and anyone
Okay,
who wants to come
please.
to Turkey and join, maybe
Oh, great.
they can
Great.
write to you directly.
Sure. Great.
On the chat part,
And
you can
yes,
write your email.
Yes.
by the way, I can read another thanks from Dr. Emre Cemal Gökçe from Ankara. Thanks so much for sharing your experience in this excellent presentation, he said.
Thank you, Emre.
And one thanks from Dr. Tuğba Moralı Güler. Thank you for this nice presentation, she said.
Thank you, Tuğba. Thank you, Tuğba.
And as far as I can see, all questions and comments are finished. I thank you again. It was a great presentation. And I give the speech to Professor Suju.
I will also write down my email. Anyone who wants to come to Turkey and make a fellowship in any kind of training, cranial endoscope, endonasal endoscope, or maybe spinal endoscope, also
Absolutely.
can write to me and I can arrange the connections. Thank you so much, Professor Gökmen Kahiloğulları. It was an impressive lecture indeed, and very
Thank you.
beautiful pictures, very good videos. Thank you for sharing all.
Thank you very much, Professor Suju. I am so happy and thank you very much for this opportunity to share to my presentation and speech with all my colleagues from Turkey and from abroad. I saw a lot of my colleagues also at this time. Thank you very much for this opportunity and to all the audience. Thank you very much.
I want to also thank to everyone who joined us, who participated tonight, this evening, or this morning, whenever, wherever you are joining, participating. Okay, so
Thank
hope
you.
to see you in real life soon.
I hope. Bye bye. Thank you.
Bye.